Next, I would like to invite Dr. as the moderator of today's seminar to read the curriculum vitae of our guest speaker and lead the session. Thank you.
Okay. Thank you, Dr. Evelyn. So, good afternoon, everyone. My name is Dorotul Ikrimah, and I am a research assistant of Psychiatric Department of Atmajaya University. Thank you for all of the participants who joined this seminar. Today's topic will be, it's very interesting. We will learn together from Professor Dr. Arnt Schellekens, PhD, about neurobiology in addiction. As the host has mentioned earlier, that understanding neurobiology is very help us to know more what happened in drugs user brain and body. So we could have the clue how to prevent and how to treat them. So today, let's invite our honored guest speaker, Professor Dr. Arnt Schellekens, PhD. Welcome, Professor.
Yeah, good afternoon. For me, it's morning still, but yeah, maybe that's even best, huh? Because yeah, I usually work best in the early mornings, so maybe that's not much of an issue. It's better that I am early in the morning. Do you have my sound? Can you hear me clearly?
Yes, it's already clear.
And I think you want to now me to share my screen, or do you still have things that you want to share with the group?
Yes, I'm sorry. I will read your curriculum vitae first.
Oh, but that's not very important, right? My curriculum.
Yes, so I will introduce you, Professor Arnt. So we have Professor Arnt here. He is a professor in psychiatry and addiction in Radboud University Medical Center, and he is also scientific director of Nijmegen Institute for Scientist Practitioners in Addiction. And also he is a researcher from Dunder's Institute for Brain Cognition and Behavior. Now let's hear from Professor Arnt Schellekens. The time is yours. Okay, so you can share your presentations now.
Yeah, thank you very much. And I'm really happy that we have this topic on the agenda today, tomorrow, and the day after tomorrow. Because I think it's really an important topic, as you said. So yeah, the addiction is one of the most common mental disorders. It has a prevalence worldwide of about 5%, and I think over 10% of the people in their lifetime develop problems related to addiction, and that usually people don't even count smoking in, because smoking levels are even higher. Yeah, in the Netherlands at least, it's gradually decreasing, but I think in Indonesia that's not that much the case. So we are now at about 20% of the people smoking, and it used to be much higher over the past years. But we have quite a strict policy on reducing smoking levels, because people die from it. And that counts, I think, for all addictive disorders. Of all the psychiatric conditions, addictive disorders have the highest mortality rate, besides maybe anorexia nervosa. That's also a condition that has quite heavy physical consequences if you don't eat well. But besides that, addiction has the highest mortality levels. And we have good treatments. So I think it's in part unnecessary that people die from an addiction. if we would be able to get these people into treatment and to treat them properly. And one of the key issues there, I think, is the enormous stigma around addiction, because it's one of the most common psychiatric conditions. It has a high mortality. We have treatments, but I don't understand why so many of my colleagues, psychiatrists and psychologists, are not that much interested in treating these people. We have something to offer. There are so many psychiatric conditions where we don't have that much to offer. For example, autism. Can we treat autism? Well, not that much. Schizophrenia. Can we really treat that? Yeah, we do have medication, but do these people really improve in their quality of life? Maybe, but yeah, I think for addiction, our treatment options are quite numerous. We have quite a lot of things to offer with good effects, and still so many of our colleagues are not that much interested in addiction. So I'm very happy that we have so many people here now, so we can talk about this. And what the reason why I think the neurobiology is an important topic to start with is because studies also at Atmajaya, they learned us that you can reduce stigma by training. So you can improve attitudes towards patients with addictive disorders by providing proper training. And one of the key elements of a training that was associated with improved attitudes was an understanding of what is going on with patients with addiction. It's not only the knowledge about the treatment or the knowledge about the diagnosis, but it is the understanding of why people behave the way they do. And to understand that, you should always also look into the biology, of course, because there you can sort of get a first idea of, this is why people are impulsive, or this is why people keep on using despite the negative consequences. Usually these people with an addiction, they do know that their addictive behavior is unhealthy. Usually you don't need to explain them that smoking is bad for your health. I don't know exactly for Indonesia, but at least here, I think everybody realizes that smoking is bad for your health. And I assume that in Indonesia, quite a lot of people also know that smoking is not good for your health, and that using cocaine or crack is not that good for your health. Mostly people know, and they experience that. But despite that, they still continue using. And then you can say, well, that's stupid behavior. But then you don't really understand why they do it and why they keep on doing it, even though they might want to quit. So I think that that understanding is a first step in reducing the stigma. And once you are there, then you, of course, need to develop the skills and the knowledge what to do if you have somebody with an addiction. So I usually build it up that way. So first try to improve understanding with neurobiology as one of the angles, then go to treatment options. And then sometimes it's also good to have some more in-depth understanding of interesting comorbidities that often come along with patients with an addiction. You can think of ADHD, depression, other mood disorders, personality disorders, but also physical conditions, HIV, hepatitis, and chronic pain and opiates, for example, which is on the topic list for Friday. So that's sort of the build-up of the three lectures that we will have together. After I can talk about this for hours, so that's not going to happen because the chair of today will not allow me to. But I will now share my slides. So I move. That takes a couple of seconds because I have to change my screens. But we will get there. So let's see. Share screen. I hope you can now see my presentation, and I hope you also now see it in full. Let's see, is that correct? Yes?
Yes,
okay,
yes,
good.
We have seen it.
So I will make, Okay, so now I also have it full screen. So yeah, I was already introduced nicely, so thank you for that. Thank you for the invitation. Once again, I'm very, very happy that we have this topic on the agenda today. This is just a picture of the Netherlands, and what you can see, and I don't know whether you see my arrow here, but here you can see the whole of the Netherlands. This is the city where I am, Kota Nijmegen, and that is in the eastern part of the Netherlands, as you can see. That is where our university is in, and that is also where the Donders Institute is. So the academic side of my work is here in Nijmegen, in the eastern part of the country, and all these places here are regional addiction care facilities covering several provinces. Together about 2/3 of Dutch addiction care, and that together is the NISPA network. So the network of addiction care facilities where we can do clinical research. So at the university, we do more the basic science, the neuroimaging, the animal models, the genetic studies. And in these addiction care facilities, we try to bring that knowledge by translating it into real life trials with real patients. So you can imagine that is really a nice place to work for me. So for today, the topic would be to focus on the neuroscience and try to understand behavior and symptoms of addiction. Then tomorrow we will go back from science to treatment. So to see whether we can understand the treatment based on the knowledge we built today. And then on Friday, we will focus on comorbidity, opiates, and chronic pain. So one of the most boring slides in my whole presentation. Sorry for that, but yeah, somehow it's important still to start always with definitions. So what are we talking about when we are talking about addictive disorders? And I focus on substance use disorders, but there is a huge overlap in symptoms and criteria between the substance addictions and the behavioral addictions or process addictions. But for the sake of clarity, I focus on the criteria for substance use disorders. And we work here with DSM-5. There is a nice overlap with the ICD that was created in the development of DSM-5 to make sure that these definitions don't differ too much. And basically, it comes down to a couple of levels which you could look at in patients with an addiction. So the most important part is loss of control. That is basically the core of addictive behaviors. People lose control over their substance consumption, whether it is alcohol, whether it is tobacco, whether it is illicit drugs. They lose control gradually. And once that has happened, then the addiction is there. So that was sort of translated into criteria for DSM-5, like using more than you planned, trying to stop, or wish to stop, but you fail to do that. So you want to control your use, but yeah, it doesn't work out. It takes a lot of time that interferes with normal functioning, either to get the drugs, to consume it, or to recover from using it. And then another symptom of loss of control is a strong urge to use, which is a core symptom, like often called craving, that you crave for using it. And that's not just wanting or not just liking. So not just, okay, it's nice to use drugs. No, it's really a need, a strong need that you cannot go without. It's like an obsession. And that is, I think, also a core symptom of addiction. So then from there, you come with sort of consequences of addictive disorders. So as I said, it interferes with your normal role fulfillment, like being a parent, being a good husband or wife, being an employee, taking up roles in society, having friends, being there for friends and extended family. those are roles that we usually have and that really suffer from the addictive process in a patient. The same is like you have negative social consequences, you have negative physical consequences, yeah, I think that's why you can understand that yeah, addiction has so many consequences for the individual and the direct environment of the individual, but also the whole society. So addiction is really yeah, a disorder that comes with a lot of negative issues. And one of the things that people used to focus on is the physical dependence, which is in fact maybe least important. Of course, people develop tolerance, they need gradually more of the substance to get the same effect. And when tolerance is there and they stop using, then withdrawal sets in, and withdrawal has a characteristic withdrawal syndrome per substance. So usually the stimulants, if you go into withdrawal, people become a little bit yeah, down, so they become slower, tired, a bit irritable, and if you use central depressants like benzodiazepines or alcohol, then usually the withdrawal syndrome is the other way around. So people get overactivated, they have increased neuronal activity, which can end up with withdrawal seizures. And of course, this takes attention if you want somebody to support somebody when he or she wants to quit substance use. So of course, this is an important aspect of the treatment, but it's only the first part of treatment. So it's not like the main thing is once you are detoxified, how do you prevent relapse? That's the core of the treatment that we'll discuss tomorrow. And tolerance and withdrawal, yeah, in fact, you see that with all kinds of substances, even simple beta blockers. So if you suddenly quit beta blockers, you also see withdrawal effects. And sometimes during the treatment, you also need to increase the dose a bit because of tolerance. So that is not necessarily unique for addiction and addictive substances. And yeah, for the DSM-5, it's defined that you need at least 2 of these 11 criteria over a 1-year period. And the addiction has to come along with personal suffering and impairment. But I think that is sort of a general issue with psychiatric conditions. So this is a bit of the basics. And what I will do is try to understand the neurobiology of the first part of the loss of control. And there is a model for that, and which I will explain in a minute, which boils down to what is the difference between these two guys. So one doesn't want to continue and seems to look at the other is, why don't you stop? Why don't you stop using? Where is your control over this drinking? And from a neurobiological view, you can, there is 2 aspects. So I'm sorry for the mistake up here. So saliency and cognitive control are the 2 key ingredients of control and loss of control. And I'll explain you how that works. This is in fact a normal brain, you could say. It's not a brain, but it's a model of output of the brain. So in normal life, we have all kinds of environmental stimuli that we observe and that we respond to. And usually we see things, we hear things, we smell things, we feel things, and we put a certain relevance to all these stimuli. So that's the saliency part. So imagine that I hear my kids right next door. That is an important signal to me because they have to go to school in a couple of minutes. And then I memorize, oh yeah, that's true. School starts at 8:30 here. And of course, my wife is also around, so she will bring the kids to school. I am now giving a lecture. So my control parts of my brain tell me, don't walk out of this room now to help the kids go to school. That's all arranged. So I can just sit here and control myself. Don't walk out of this room. So that's how the brain connects stimuli in the environment with previous experience, with the memory network, and then from there, see which type of behavior is the best response to those stimuli in the environment. That's how it usually works. So what in an addicted brain? That's completely different. So an addicted brain is hijacked by stimuli that are related to substance use. Though all those stimuli, it can be smell, it can be a certain place, it can be certain people, it can be seeing something on television, hearing something. That any stimuli that are related to substance use receive so much importance because of strong memories of prior use. So there's a very strong connection between the salience network and the memory network, making every single stimuli in the environment that relates to substance use directly noticed and becoming very important. And this urge, this craving to use develops. And what is very interesting is that normally the control network inhibits this drive to do something. And in patients with an addiction, it's just the opposite. The drive overrides the control system, the control network, in order to make somebody use. So this whole brain works very different from a non-addicted brain. And I will go into a little bit more detail using mainly neuroimaging findings to explain this model in more detail, so you really understand how this works in the brain. And basically, it is this model, a horse and rider model. And this is a very ancient model. So even the Greek philosophers already posed this model for human behavior. And they said, well, human behavior is like a horse and a rider. So the horse gets all kinds of stimuli and wants to respond with a lot of power, either going for food, running away for a snake, but the power is in the horse. And then there is this rider that wants to sort of control that power and sort of inhibit not to go after every stimuli. So just thinking, okay, this one is important. Yes, this one is important. So now I will move left. Oh, well, this is not that important. Now I will just continue straight. Now I slow down. Now I increase my pace and speed. So there is this interaction between the force of the horse and the control of the rider. That's basically a very, very simple model of human behavior. And if you look at the brain, you could say, well, this horse, that's the midbrain. This horse is the affective power of emotions. So all kinds of emotions develop in response to what we experience in the environment. And then the control network, which is located in the prefrontal cortex, decides what to do with those emotions. And sometimes you let your emotions run free. And if you are very anxious, you want to run away. But in other times, you think, well, I shouldn't be really afraid of a spider. I mean, I can just stay in the room and just continue my lecture, even though there is a spider on the wall right here. So the prefrontal cortex overrides then the horse, the power of the horse, and controls the behavior. So basically, that is a very, very simple model of behavior. And you could say in a situation of an addiction, the horse is trained to only detect and go for drug-related behaviors. So the horse will detect any stimulus that is related to substance use and put all the force into making that happen, that they can use the drugs. And the rider, in a case of an addiction, is not strongly connected with the horse. The rider is sort of, yeah, well, it doesn't really control what the horse wants. So there is a disconnection between the midbrain and the prefrontal cortex. That's basically the most simple explanation from neuroscience that you could give. So let's focus on the horse first. And if we have time, we can also talk a bit about the rider. But I think really understanding this horse part of the brain is already quite a challenge. So I will talk you through. And one of the questions that you probably received prior to this lecture is, well, which of the what dopamine areas do we have in the brain? And maybe you thought, well, why think about dopamine areas? We'll get there. But it is important to just get the bigger picture first. So in the brain, we have four dopamine circuits. So you all know the nigrostriatal dopamine pathway. So it goes to the basal ganglia. It is related to Parkinson disease, Parkinsonian motor symptoms due to antipsychotics. So this pathway from the substantia nigra towards the basal ganglia controls movement. And if dopamine receptors go down there, then or are blocked by antipsychotics, we will get these Parkinsonian symptoms like rigidity, tremor, these kind of things. Then we have other adverse effects of antipsychotics, and usually I use the example of antipsychotics because they block dopamine receptors, and then you, from the symptoms that they give, the adverse effects, you can understand the dopamine pathways. So if the dopamine receptors down here are blocked, which is the tuberoinfundibular pathway, running from the hypothalamus to the pituitary gland, that's a regulation of our hormones. And the dopamine receptors are involved in two hormones. So one is growth hormone and one is prolactin. And if you block dopamine D2 receptors right here in the this tuberoinfundibular pathway, you will increase prolactin. And increased prolactin will stimulate development of the mammae, of the breasts, and stimulate milk production. So you can get a galactorrhea. So that's one of the adverse effects of antipsychotics, which it's completely understandable if you know that this dopamine pathway is there. So then we have the mesocortical pathway. So that comes from high in the tegmentum, behind the brainstem. That's where the dopamine neurons are, and they project to the prefrontal cortex. So that is more involved in attention and cognitive control. And that's also why patients with schizophrenia who receive antipsychotics sometimes complain about cognitive issues that on the one hand already arise from schizophrenia, but are sometimes increased by the antipsychotics that we provide them with. Another example is ADHD, where you also see that dopamine issues in this pathway play a role in inattention and problems with cognitive control. And that's why people with ADHD can be that impulsive. So finally, the fourth pathway, which is maybe the most important one for the topic of today, which is addiction, that is the mesolimbic dopamine pathway. Mesolimbic, so that projects from high in the tegmentum, so in the brainstem, towards the limbic system. And this is an area that in the literature you will also see as nucleus accumbens or ventral striatum. And this is often called the reward pathway. So dopamine that is produced here and released here, if that is released here, people usually say, well, that feels good. And all kinds of behaviors can stimulate this dopamine release right here. And if you would provide antipsychotics and you block this pathway here, what would you get? Yeah, you block a reward circuit. So taking antipsychotics that block dopamine receptors there will increase anhedonia. And in fact, that's what many people with psychotic disorders receiving our antipsychotics are complaining about. They don't feel happy anymore because this hedonic pathway is blocked. And that's really an issue because sometimes people don't want to take these antipsychotics anymore because they don't feel well on them. And I fully understand why. Still, it's important that they take medication, but it's also important that we think about alternatives, like medication that does not block the dopamine D2 system that hard. For example, clozapine. Clozapine has other disadvantages, of course, but for some people, it is really an improvement over the more classic antipsychotics. But that's another topic. So this is the dopamine pathway where it is all about an addiction. So from high in the brainstem, ventral tegmental area, to the limbic areas, mainly nucleus accumbens / ventral striatum. And as I said, if we do things that are nice, like jogging, I missed my jog this morning because of this lecture, but that's not a problem. I have other very rewarding things to do right now. But this brain area responds to all kind of nice behaviors. So that's social interaction, that's food, that's drinking, but it's also reproduction. Like sex and orgasm are very stimulating for the brain dopamine system. But the issue is that addictive drugs are by far more have a more tremendous effect on this dopamine system. So if you take cocaine or if you take heroin, the dopamine that is released in this ventral striatal area is much higher than for any other behavior that you can think of. So if you ask addicts, usually they will say, well, it's better than sex. And that's because the dopamine that is released is so high and it exceeds any other natural levels that we would have. So this is basically why we tend to repeat behavior. If something is nice, we tend to repeat it. And if drugs are that stimulating for the dopamine system, there is this tendency to repeat the use of that drug, of course. And that's where the story of developing of an addiction starts. So just a few examples showing you activation of this striatal pathway, the ventral striatum or nucleus accumbens, when we do things that are rewarding. Here you can see people playing a video game in the scanner, and this very same area becomes activated. Here is people getting money when they are in the scanner, and that is rewarding. We do a lot for money, so getting money is rewarding and activates the very same brain area. Here in the Netherlands, there has been one study in Groningen, that's the northern part of the country, where they had people getting an orgasm in the scanner. I don't know, I wouldn't participate in a study like that, but they did it, and they saw exactly the same brain areas becoming activated. Here in Nijmegen, we are a little bit shy, so we did it with beer and water, and we saw exactly the same areas coming up. And this is a study with amphetamine, and you see again the very, very same brain area responding. So these different studies show clearly that this area in the brain, this ventral striatal area, responds to rewarding behaviors and use of addictive substances. Then of course the question is, how does that work? And this is just a model. So this here right in the middle would be the dopaminergic neuron projecting from the tegmentum high in the brainstem towards the striatum, the ventral striatum, the nucleus accumbens. So this is where the synapse is. And all the different addictive substances have their own entrance on this dopamine system. So the stimulants, they work at the synapse in the striatum, and they block the reuptake of dopamine back into the neuron. So when dopamine is released, usually it is sucked back into the neuron, and when you block that mechanism, then the dopamine will stay within the synapse, and that's how stimulants work. But for example, alcohol works through GABA and glutamate. So it inhibits the interneurons that dampen the dopamine neuron, and it activates glutamate, um, um, thus increasing dopamine activity here. Opiates have their mu opiate receptor here, cannabis has the cannabinoid receptor here, nicotine has the acetylcholine, the nicotininergic acetylcholine receptor here. Then we have some serotonin receptors working here. But one thing is interesting, that serotonin, so substances working on serotonin mainly, are not that addictive. So for example, ecstasy works mainly through serotonergic pathways, and that's not really addictive. So this connection with serotonin is rather weak, and the others are far more important. I don't know whether it is, people are already asking questions. Maybe I should ask the moderator for this morning. Are there already a lot of questions in the chat? Because I really hope that people can understand what I'm telling. So if not, maybe I should have a short pause.
Oh yeah. For now, there are no questions still from the audience.
Okay, so maybe it is good. So if one of the people listening thinks, well, this is too fast, I cannot understand what it anymore, please send a message in the chat, and then yeah, please interrupt so that I can sort of try to explain again, because it's important that you understand the story, of course. Otherwise, you're just sitting listening, and it's not going to lead anywhere.
Thank you, Professor. For now, for me, it's really clear.
Okay, so
yes.
I will continue then. I will continue. So that is the basics of how drugs work. But now, what is going on in the human brain of somebody who has developed an addiction? And this study is already quite old, as you can see here. So it's about 20 years, but this was the first study showing a similar deficit in the brain in people addicted to different substances. So I'll explain what you see. So what they did is injecting raclopride, which is an antipsychotic, which blocks the dopamine D2 receptor. And they labeled it with a radioactive label. And then, of course, the raclopride binds to dopamine D2 receptors. And because it's radioactively labeled, when you put these people in the scanner, you can see where the raclopride goes, right? So if the raclopride binds to dopamine D2 receptors, and there are many dopamine D2 receptors in the midbrain, so in the nucleus accumbens, the reward pathway, then you have a lot of radioactive signal there. So that is what you see here. So blue or purple, then there is not so much dopamine D2 receptor binding, but going up to red, then there is a lot of dopamine D2 receptor binding with this raclopride that was radioactively labeled. So healthy controls, people not using drugs, they have quite a lot of dopamine D2 receptor binding in the reward circuit of the brain. We saw this area before, that this is the very same area. So then if you compare with people taking drugs, well, this is immediately clear. There is a difference here. There's a difference here, there's a difference here, and also here. It's the same direction of effect. So there is reduced due to receptor binding. And that is across different substances: cocaine, methamphetamine, heroin, and alcohol. So this suggests that this dopamine system, this reward system, is, well, a sort of less developed or downregulated. At least there are less receptors there in this reward circuit in patients with an addiction. Less compared to healthy controls. And then the question is, of course, what does this mean? Where does it come from? And that would be a next step to think about. What does this mean? That's the first question. So in the literature, there has been a huge debate on whether this reduction in dopamine receptors would lead to either reward deficiency, meaning that people have less dopamine receptors, so they feel less reward, so they feel anhedonic, and that's why they tend to use substances, because they are sort of anhedonic, and taking drugs sort of release them from the anhedonia. That's one way of thinking. The other way of thinking is, well, there's less dopamine receptors there, so anything that stimulates them is already making it very important. So these people respond to any stimulus in the environment, and that's why they are impulsive, and that's why they tend to use. So you go, oh, somebody's drawing on the screen. So you go from reduced number of dopamine receptors to that they respond to all kinds of stimuli in the environment, and that's why people tend to react impulsively to all these stimuli. And so in the one example, the reward deficiency, this reward circuit is less sensitive, and in the other explanation, the reward system is more sensitive than healthy controls, even though there are less receptors. And both explanations are there in the literature, which cannot, I mean, it's sort of confusing to have these two explanations in the literature. So, and there are MRI studies supporting both directions. So that's also confusing. How can that be true, that the brain responds less to reward and more to reward that in the same condition? That's strange. So a couple of years ago, we thought, well, we need to try to understand this better, because yeah, this is really not going to help us. So what we did is that we asked all the studies that were published on this topic, we asked for the original data. And people were very helping to share the original data, so we could analyze all these data together again. So we had a lot of MRI data and put that in software at the Dundas Institute to see whether we could solve this topic. So that was published a couple of years ago, together with my colleagues from the Dundas. And in fact, what we found is what you can see here. So this is the whole study, all addicts versus all controls. And what you are looking at is brain activation during a reward task. So these people were in a scanner, and when they performed well, they would receive €1. And that is rewarding. So what you can see is that in the addicts versus the controls, there was less activation in the reward circuit during this task. And if you split out for people taking alcohol and drugs or those with gambling disorder, you see the exact same pattern. So this is not unique for substance use disorders. It also applies for gambling disorder and maybe also even for other behavioral addictions, but there were not that many studies on, for example, sex addiction or porno addiction or whatsoever. So, nee, jongen. So what you can see next is that this reduction in reward sensitivity in the brain um, does not mean that this brain area is not responsive to anything. Because if you have, and this is an example of people with alcohol use disorder, alcohol addiction, if you provide them with alcohol cues, then this reward network is highly activated. So you can see here the ventral striatum, that is here, it is more active than in healthy controls when you provide these people, these patients, with alcohol related stimuli. It can be pictures, it can be short movie clips. And then in the scanner, you see this reward area really responding hard. And what we also know is that the activation pattern in the ventral striatum in response to these kind of stimuli correlates with subjectively reported craving, which is, of course, very important in relapse. So this urge to use is a key driver of relapse. So the amount of activation here in the ventral striatum in this study was also related to the probability of these patients to relapse after their treatment, which is, of course, very important to realize that we here now have a core mechanism in the pathophysiology of addiction. So the ventral striatum is less responsive to all kinds of rewards, leading to maybe a sort of anhedonia, reward deficiency, but it does respond to substance-related stimuli, which then in turn mediates subjective craving, a key symptom in addiction, which then is predictive of relapse. And that is, I think, a very important understanding of addiction. Another issue in this study is that they repeated the scanning after 3 weeks. So here, the control brain, here is the scan early in abstinence, here is the scan after 3 weeks of abstinence. And what you can see is that with abstinence in this patient group, the brain seems to recover a bit and the brain becomes less responsive to these alcohol cues, which is interesting because that doesn't happen in all studies. And so this study shows that would mean that people with in abstinence for a longer time, then the brain will recover within that couple of weeks, which is not always the case. We know that from other studies, and I'll explain to you a bit more about that later. But in a way, it's also hopeful. So let's cherish this finding and be happy with that. So I already told you that this cue reactivity of the ventral striatum is related to craving. And also here there has been a nice meta-analysis of different studies on cue reactivity across different substances. And again, people were in the scanner, were provided with either pictures or videos related to substance use. And what you can see here is all the studies on nicotine, alcohol, and cocaine show that this reward area responds to these cues more in the patients than in the healthy controls. So again, you see across different substances the same picture that the brain has higher cue reactivity in case of an addiction than in healthy controls. And also they observed that the activation, the amount of activation in the reward pathway correlated with the level of subjective craving. So we really have a core issue here, a saliency pathway. There is reduced dopamine D2 receptors in addicts in the reward pathway, which relates to anhedonia, cue reactivity, and craving, what we see in our patients. And I think if you ask your patients with an addiction about these terms, they will report craving, they will report cue reactivity, and they will report anhedonia. And now you understand where that comes from. that comes from the midbrain, from the nucleus accumbens. So, Dorothee, do we have any questions or remarks so far?
Yes, there is one question from Dr. Florentina Reddy. So I will read to you, Professor. Does each substance have the same pathophysiology or onset? If not, what substance will have the worst effect or the fastest onset?
Okay, yeah. So that's a nice question, because you can see from these pictures there is a similarity between the different drugs. But these drugs are also different, of course. So there are similarities and there are differences. And in some drugs, on average, the development of an addiction goes faster than for others. Some drugs are more addictive than others. So the drugs that are most addictive are, in fact, stimulants and nicotine. Those are the most addictive substances. Then we have opiates and alcohol, and then comes cannabis, and then comes coffee. So there is a difference. And one of the ideas is that this difference is caused by the amount of dopamine that is released after using it, and also the speed of dopamine release after using it. That's why, for example, using drugs intravenously, injecting it, is more addictive than eating it, because if you inject, it goes straight to the brain and it has a very fast, strong dopamine release. While when you eat it, there's a slow onset of an effect in the brain, so there is dopamine release, but it's more gradual, so then it's less addictive. That's, for example, why methylphenidate, which is a dopamine agonist, which is a stimulant, if you take it orally in a slow release formula, it's not problematic. It's not that addictive. If you take it immediately release, it becomes a little bit more dangerous. So the risk of developing addiction is a bit higher. But if people crush it and then snort it, then it is really addictive. So if you have Ritalin, you have methylphenidate, and you crush it and you snort it, you can sell it. You can sell it on the market because it's really a stimulant. Maybe not as potent as cocaine, but it is a stimulant. So there are different, there are various differences between these substances relating to their addictive potential. It's a nice question.
Professor,
yes?
So I would consider that why nicotine is the fastest addiction, because the mode of the administration is from smoking, right?
Yeah, so it goes in here, poof. It goes to the brain very, very fast.
Yes. Okay.
And what is also an issue with cigarettes is that the companies producing cigarettes, they put all kind of additional addictive substances in those cigarettes that to maximize the dopamine release. And we think there's sometimes that it's just a cigarette, but it's not just a cigarette. There are these companies, the tobacco industry, they put in all kinds of ingredients that stimulate the dopamine system in order to have people become addicted as soon as possible, preferably after the first cigarette, because that's their selling point. That's their business case. If it would not be addictive, then they wouldn't sell. So they have a reason why to make a cigarette as addictive as possible. And to make it even worse, they try to this testing of the hazardous effects of cigarettes. They try to downplay that a bit by playing around with the filters in the cigarettes. So it's really a bit of a nasty industry, I would say, trying to take advantage of this brain system that makes their business case so successful. It's really an issue.
Yes. Yes, I agree, Professor. And then there is a comment from Dr. Florentina. I'm sorry. Thank you, Professor, for the answer. But there any other factors apart from the substance itself, for example, like genetics?
Yeah.
Yes.
Yeah, sure. So the substance itself is like a first step, like difference in substances, but there are also differences between people. And there are also differences in their environments. So what makes one person more vulnerable than the other? And that is genetics, that is well, being traumatized, that is how you are, in what kind of social environment you are, poverty. There are all kinds of factors that also influence the risk to become addicted. And yeah, I don't know how much time we still have left, but yeah, I could explain a lot about that, because all these kind of effects play a role also in the dopamine system. So there is strong genetic effects on the dopamine system. There's strong environmental effects of the dopamine system. And I don't know what you think, to what extent genetic factors play a role, but I could sort of skip a few slides and show you a bit about that. Let's go to this one here. And that clearly shows that, yeah, all kinds of conditions, of course, are heritable to a certain level. And we see that the psychiatric disorders are relatively heritable, but within the addictive disorders, or within the psychiatric disorders, the addictive disorders, alcohol, but also cocaine, the addictive properties of the heritability is around 50 to 60%. So there's a lot for the environment and for the psychology, the remaining 50%, but nearly half of the risk to become addicted in general can be related to heritable factors. And of course, for one person, the heritability might be stronger than for the other. And some people, the whole family is addicted, so it's really a strong genetic component. But in others, for example, trauma plays a more important role in the vulnerability for addiction. But on average, it's about 50 to 60%. So maybe are there other questions for now?
Yes, there is a question from Dr. Eduardo. So he asks about, after a person with substance use disorder stop their substance use and doing healthy lifestyle for months or even years, will their brain structure also getting better like before the substance use problem?
Wonderful question. I love it. I love it. So I will show you. This is an experiment in monkeys. So maybe I do one step before. So this is an experiment in monkeys. And what they did is they provided these monkeys with cocaine. So these monkeys had a 1 year access to cocaine. And they measured dopamine D2 receptors, the same way as the previous pictures with the raclopride. And what you can see, these monkeys, they were cocaine naive. They normally monkeys don't have access to cocaine, so they never used cocaine in their life. So you can see that there is a ventral striatum, this accumbens, this reward pathway. There's a lot of dopamine D2 receptors there. And these are pictures of individual monkeys, right? At baseline, never cocaine before. Then half a year of cocaine use, you can see what happens in their brains. And then 1 year of cocaine use, you can see what happened in their brains, right? So the use of cocaine damages this reward pathway and increases the anhedonia, increases the craving, and why it is so difficult to stop using. And you need more and more to get to the same effect, because there's just less dopamine receptors. So if you want to get the same effect, you take more. But it will not work because the dopamine system becomes more and more damaged. So this is really a nasty picture. And if you look at the group average of the monkeys, that's what you can see here, that even after 1 week in these monkeys, the dopamine D2 receptor level is already down with 15%. So we do not exactly know how this translates to humans, but we think that there is a reduction in dopamine D2 receptors of about 25% in substance users. A down regulation of about 25%. Your question is, what happens afterwards if these, in this case, monkeys, are kept abstinent? And in monkeys, that's easy, right? You just put them in a cage and you don't give them cocaine. So that's easy to control. In humans, it's much more difficult. But in these monkeys, you can control them. And here you can, so I had, in fact, a question on that for you. So what happens after abstinence? So I will show you. This is a picture of one monkey. So the first picture on the left part of the slide is like the baseline measurement. This monkey never had cocaine in his life. And then he started using for a year, and then after that year he was kept abstinent. And here you can see what happens after 227 days of abstinence. And now you become sad, right? I mean, there's no recovery at all. And this is really, yeah, I mean, I'm impressed every time I tell about this study. It's impressive that you don't see that much of recovery in the brain in this monkey. But the exciting thing in this study is that they didn't look at the average recovery, but they looked at the recovery for each individual monkey they still had in their study. And that's what you see here. So what is interesting about this is that there is so huge variation between the monkeys. So these are the individual subjects, the individual monkeys. This is their dopamine receptor availability after 1 year of self-administration. So they had 1 year of self-administration of cocaine, and the average reduction in dopamine D2 receptors was about 20 to 25%. Then you can see what happens with these individual monkeys after 1 week of abstinence, that is this column, then 1 month of abstinence, then half a year of abstinence, and 1 year of abstinence. And if we start at the bottom of the table, you can see that this guy here, after 1 week of abstinence, the recovery is almost back to 100%. So this monkey with 1 week abstinence feels fine again, which mimics the data that I showed earlier of these alcohol addicts recovering with 3 weeks of abstinence. This is really good news. If you go one up to this individual monkey, yeah, it's also full recovery, but after half a year. So it takes just simply longer. This guy here is 1 month. If you look at these two on top, that's sad. There is hardly any recovery over a 1 year period. So there is huge inter-individual variation there. And that's, I think, exactly what you see in your patients. Some, if you get them abstinent, they recover, they feel fine, and they think, oh, well, thank you, doctor. You helped me so much. I can enjoy life again. I'm back the old husband that I used to be. Everybody happy. But some people, 1 year of abstinence, you keep them on your ward, and they still feel anhedonic, and they still have strong craving, and they are not happy with it at all. And this is just variation that is there in reality, and we have to face it. Maybe for these people, for the people that don't recover within a year, yeah, you should think of different approaches. And you could either think of more intense supervision, so intensive treatment, Maybe you put them in a safety house where they cannot use drugs. But also maybe we should think of some of these people, putting them on long-term substitution. Maybe abstinence is not the way to go for these people because their brain is not recovering at all. For example, in heroin, we could say, okay, maybe we should not try to get abstinence, but maybe we should do methadone substitution for a long, long time. For alcohol, you could think of baclofen. For stimulants, you could think about dexamphetamine. It's medication that sort of substitutes the drug. But who should we aim for abstinence, and who should we aim for substitution treatment? And that's something that we are now doing based on clinical judgment. But maybe we should use these kind of measures to make the proper indication, that to help decide which patient can go for abstinence and which patient should be in substitution treatment. We don't do that yet, but it's a way to go, I think, in neuroscience. So wonderful question.
So it means that the treatment also is personalized, right?
That's the way to go, definitely. So yeah, tomorrow we will talk about treatment, but yeah, I think it's very important to further our understanding of how the brain works and how that relates to personalized treatment, because I think then we can improve our treatment outcomes.
Yes, thank you, Professor Arnt. It's very clear.
Okay, are there other questions or?
Not yet.
Not yet?
Yes.
So what I could
do? I'm sorry.
Yeah.
So the structure will remain the same or not? So it's individually, right?
So yeah, if we talk about dopamine receptors, is that structure or not, right? So in a way, receptors are a structure of the brain, but at a very small scale level. You could also look at volumes. And for example, prefrontal cortex area, that's the control area of the brain, we see reductions in volumes. So it's on a micro level in these deep brain areas where you can see all kind of changes, but these areas are so small that it's really hard to detect volume changes because they are already very small. So then to detect any change from already small structure is very difficult. But there you find these differences in dopamine receptors and so forth. But the prefrontal cortex is much larger, so it's easier to detect changes in these volumes, and you find them. So there's reduction of the cortex volumes, and there again, I think I have that picture somewhere. Yeah, if you look at the prefrontal cortex, yeah, here. So in addiction, you see that the prefrontal cortex, the control center of the brain, doesn't function that well. And so that's what you can see here, that the loss of control is not only due to the midbrain that contributes to craving, but also because the prefrontal cortex is functioning less well. So here in the above panel, you can see the healthy control. And here you again see cocaine addicts. And you can see that the prefrontal cortex, the front brain of the area where my arrow is, you can see that there is less activation. So the prefrontal cortex is less active in addicts compared to controls. And if that is your control center of your brain, yeah, of course, if that doesn't function, it's very hard to direct your behavior. So yeah, the control network should be active in order to guide your behavior. It is not active, yeah, then yeah, the midbrain takes over. And when there's craving, you go for it, and the control network will not stop you. So there is a nice study that measured in addicts the differences in prefrontal cortex volumes in relation to relapse, to the follow-up after treatment. So here on the axis here, you can see the time to relapse. And every time that there is a relapse, then the line goes down. And you can see on average that people relapse, right, in over a 2-month period. But what is interesting in this study is that they took of the whole group the 20% with the largest prefrontal cortex volumes, then the 20% a bit smaller, then 20% again a bit smaller, until they have the 20% group with the smallest prefrontal cortex volumes. And what you can see here is that the smaller the volume, the faster the relapse and the higher the relapse rates. So the ones with the largest prefrontal cortex volumes, the 20% largest prefrontal cortex brain areas, is the yellow line. And then you can see that about 70% remains abstinent of that group. Whereas the 20% with the smallest prefrontal cortex volumes, that's the purple line below, all of them have relapsed already within 40 days. So as the midbrain has a relationship with craving and with relapse, you also see that the prefrontal cortex, the control area, has a relationship with inhibition and with relapse. So maybe we should not only measure the midbrain when we personalize our treatment, but also the front part of the brain. Because the ones that have lower volumes, maybe we should help them control their behavior by giving more intensive psychotherapy. Or maybe we should keep them in treatment for a longer time. I don't know the situation exactly in Indonesia, but in the Netherlands, the government and the insurance companies want us to treat as short as possible. They really put pressure, like, can you do five sessions of psychotherapy? Why is that not enough? And I think for the people with the yellow line, it might be enough. Just 5 sessions, talk about their behavior, and they will gain control again. But the ones with these small prefrontal brain areas, 5 sessions not going to work. Their control network is not working. So how in 5 sessions would you like to get them back on track? It's not possible. So then you may need more sessions. And that's something that we have to explain to our governments, to our policymakers, to the insurance companies, that we have to individualize our treatments, and that for some, short is fine. But for others, we need more intensive long-term treatment approaches, or maybe even substitution treatment. And that has to be paid for. You cannot only pay for 5 sessions, and the ones that are not going to recover, it's their own fault. That's not how the brain works. It's not a choice whether your brain recovers or not. That's not a matter of choice. It's genetics, it's the environment, it's psychiatric comorbidity. Yeah, and we should not leave these people suffering. We should help them.
All right.
Are there other comments or questions?
For now, there are no questions. But maybe I would like to invite all of the participants who would like to ask. You can ask directly by raising your hands, or maybe you can drop your question into the chat box. And also, if you want to open the camera, the video, it will be great. So we feel not alone, right, Professor Arnt? Yes. Okay. Please continue, Professor Arnt.
I could add one other exciting study. I think it's really interesting. It's again in monkeys. I love monkeys, but I don't know. Sometimes these studies are really impressive. This is a study, and you probably know about alpha monkeys, right? So you have these monkeys that are on top of the rock. They are the big chimpanzee, and they have the first choice when they get food. They are the ones to pick the best bananas. They are the ones to pick the best wives that they want to have sex with. The alpha monkey is really in a good position in the group, right? And then you have the subordinate monkeys, and they come last. They are always bullied. They get the punches of the alpha monkey. They are in the lowest part of the monkey society. So you know these differences, right? So the interesting thing is you could look at these monkeys, at their brains, at their dopamine receptor system, and you could look at their self-administration of cocaine. And what is interesting in this study is that they measured dopamine receptors when these monkeys were individual in their cage for a prolonged time, and when they were in the group for a prolonged time. And what is interesting is that these monkeys, the alpha monkey and the subordinate monkey, if they were in their cage individually, so on their own, and you look at the dopamine D2 receptor density, there is no difference. So this 2.49 is the level of dopamine D2 receptors in the dominant, in the alpha monkey, and the 2.40 is the number of the level of dopamine receptors in the subordinate monkey. No difference. But it becomes interesting when you put these monkeys in the group. This is what happens in the brain of the dominant monkey. It's an increase of 22% of dopamine receptors. So it goes from 2.49 to 3.04. 20% increase in dopamine receptors. And this subordinate monkey that is bullied and that has no good chances in the monkey society, is there an increase in dopamine D2 receptors? Hardly any. Only 3.9% increase. So they go from 2.40 to 2.49, which is in fact within the margin of a sampling error. So there's nothing there. So the environment, the social environment, has an impact on the brain, on the reward system of these monkeys. So our brain is not static. We have a plastic brain, and depending on the context that we are in, the brain changes. And now the most exciting question is, who of these monkeys will take more cocaine? Is that the alpha monkey or is that the subordinate monkey? What do you think? What do you think? Which kind of monkey with high levels of dopamine D2 receptors in the group? The alpha monkey? Or the monkey with lower dopamine D2 receptors, the subordinate monkey? And if you think about what I already told you about dopamine D2 receptors and addiction, then probably you could think of that the ones with lower dopamine D2 receptor levels would take more cocaine than the ones with higher dopamine D2 receptor levels. Because that's what we saw so far in addicts and in the monkeys taking cocaine in the other study. And that's exactly what they found. So here you can see the blue line, that is the subordinate monkey, and the red line is the dominant alpha monkey. And on the y-axis, you can see the amount of cocaine consumed. And you can see that this subordinate monkey takes more cocaine. So I think what is the message here is that we discussed genetics and heritability, explaining maybe 50 to 60% of the risk of addiction. But it's not only genetics. It's also environment. It's also trauma. And this study really shows that the current environment that you are in, the social context that you are in, affects the brain and the risk to take substances. Not because of peer pressure, but just because of the quality of your social interactions affects your brain. And that brings certain vulnerabilities or protective factors. Like this alpha monkey is protected in a way, is resilient to cocaine use. And that's also good news. So if we can help people regain their role in society, that might also help them become more resilient to relapse. So many of our patients are not in the best positions in society, and that will not help their recovery. But if we can help them to get back in a good relationship, to get back in a professional role in society, that can really stimulate their recovery. And of course, we should be aware that their brain, not all these brains recover that quick. So some might relapse, and maybe not one time, but maybe 2 or 3 or 4 or 10 or 20. But we shouldn't give up, because there is a potential for recovery. And in some, maybe we should not go for abstinence, but for substitution. And then once they are stable on for example, methadone, that stable situation might help them to work on being a father, a mother, or a professional, or whatsoever. And then once that is their life is back on track again, they might still be able to taper down the methadone and become abstinent in the end. So sometimes the goal should not be first to work on the addiction, but first to work on other things that are important in life. And then after that, talk about the substance again. Sometimes we just take the wrong order, and we want people first to get off their drugs and then work on the other things. But that's not always going to work. Are there any remarks here or questions?
There are no questions
No
from the
questions?
audience. Yes, Professor. So maybe I would like to ask question.
Yeah, sure.
Yes. So is it possible to become dependent without being addicted?
Yeah, sure. Yeah. So can you be dependent without being, without being addicted? Yeah, for sure. I already provided the example of beta blockers. So all kinds of medication give physical dependence in a way that there is tolerance. So you need more of the substance to get the same effect. And when you stop it, you can get withdrawal symptoms. And for example, also when people take a low dose of benzodiazepines or opiates for a long time, then they will develop tolerance and withdrawal, even though it's just a low dose. If they just take one tablet oxazepam of 10 milligram, you will develop tolerance, and when you stop it, you will notice it. There will be some sort of withdrawal. Not that severe, but you will notice. That is physical dependence, but it's not loss of control. So people just taking the same one tablet or even half a tablet every day, that's not loss of control. So that's not really addiction. That's just the physical part of tolerance and maybe a bit of withdrawal. So I think that is, it's important to make this distinction between the two.
All right. Thank you, Professor. So in this chat room, there are still no questions.
Okay. And I think we had until 10 minutes from now, or?
It's about 15 minutes.
Yeah, it's about 15 minutes. So one of the questions that I had for you is about, maybe you should know by now after the story that I shared with you, the correlation between dopamine D2 receptors and cocaine self-administration. So this is a study where they measured the dopamine D2 receptors in the brains of monkeys. And then these monkeys were given cocaine, access to cocaine. And then the question is, like, there is variation in dopamine D2 receptors in these monkeys. They never had cocaine before. You just measure their brain and you see some have higher and some have lower levels of dopamine D2 receptors. That's just how it is. There is individual variation. And now the question is there a relationship between the number of dopamine receptors in the brains of these monkeys and the amount of cocaine that they will use when they get access to it? And I hope that nobody of you thinks the first option anymore. After talking about dopamine receptors and cocaine use and substance use the past hour, I hope you all would think there should be a relationship between the level of dopamine D2 receptors available and the amount of cocaine use in these animals. And then the question is it a positive or a negative correlation? So a positive correlation means higher dopamine D2 receptor levels at baseline is related to more cocaine use in the year thereafter. And lower level of dopamine D2 receptors is less cocaine use. A negative correlation means high dopamine D2 receptors at baseline is associated with low levels of cocaine use, and vice versa. So that's basically the question. And probably you are now thinking about this, like, what would it be? And I should give you the answer. So this is what they saw in this study. And what you can see here, it's a bit difficult table, but I'll explain it to you. The first column is the weeks of the experiment. So the first week of cocaine use, the second week of cocaine use, and so forth. So these monkeys were given 10 weeks access to cocaine. And then you can skip all these columns and only look at the last one. The last column shows the correlation between the dopamine D2 receptors levels before the cocaine and the amount of cocaine these monkeys used. And what you can clearly see here is that not in the first couple of weeks, but after 4 weeks, there is a strong negative correlation. So you can see here it's around minus 0.80. So that means that the monkeys with high levels of dopamine D2 receptors take less cocaine, and the ones with low levels of dopamine D2 receptors take more cocaine. And that matches perfectly with the other studies that I already showed you. And I think, and I don't know whether you know literature on behavior, but usually in social science, we are very happy if we find correlations of 0.4, 0.5. Because then we say, well, there's quite a strong correlation, because there's so many things that influence behavior, so many things that makes us behave in a certain way, that if you find a factor that has a correlation of 0.4 or 0.5, it's really an important factor. But here you see correlations of 0.8. That's really, really impressive. So I think it's a very convincing study showing that variation within this dopamine pathway, either being genetic, being based on psychology, being based on the social relationship, being based on a traumatic experience or whatsoever, that really has an impact on the vulnerability to use addictive substances. And these are factors that you cannot choose. I mean, your heritable composition is what you get from your parents. Trauma, I think nobody deliberately chooses to become traumatized. Being an alpha monkey or more a subordinate monkey, I think nobody chooses to be a subordinate person. It's also the opportunities that you get in life, and then these are not choices. So of course, people have a responsibility for their behavior, and I don't think that we should tell addicts, "Oh, you cannot do anything about it," because that is not really motivating. But it is still important to understand that what we sometimes tend to think in terms of stigma, these people are just making the bad choices and they are weak persons and they are not good, they don't have a good religion or whatever you have for thoughts about these people. It's not that simple. It's not just a matter of choice. And I think that the neurobiology can really learn us that it's not a matter of choice, and that these people have a severe condition and that they need proper treatment from us. Yeah, well, I could talk for hours about it. As I told you, I also have a lot of extra slides. I don't know whether it is needed to go over all these slides. Probably not. Maybe I could, if there are no questions.
Yes, there are no questions.
I could end with a short video.
Yes.
This video shows us the interaction between the prefrontal brain and the reward area of the brain. And it also shows us variation between individuals. I don't know whether you know the marshmallow experiment. That is an experiment. I love it. I love it. So what they do is they have kids in their office and they provide them with one marshmallow. So I still need to take my breakfast. So I have here a bowl of muesli and I have one. But if I do not eat it now, then after this lecture, I reward myself with 2. But I have to control myself. So I can approach it. My midbrain will say, it's rewarding because you didn't have breakfast yet. It's so nice to take your breakfast. So I want to take it. But then my prefrontal cortex says, no, you control yourself. You can have the whole bowl of muesli after the lecture, okay? So just wait a couple of minutes until it's over, then you can have your breakfast. So this is a struggle between the approach areas of the brain, the reward network, and the control network. And I'll put them away because my control network works fine. And I'll show you this nice movie, and I hope you can hear it. Can you hear anything or not? I think you don't have sound.
Yes, you can hear it, Professor.
Okay, sit in that chair. Okay, sit in that chair. All right, here's the deal. Marshmallow for you. You can either wait, and I'll give you another one if you wait, or you can eat it now. When I come back, I'll give you another one, so then you'll have 2. But stay in here and stay in the chair till I come back, okay? All right. I'm gonna go do something, and then I'll come back.
It smells yummy. It smells really good.
So you see these kids working with their control networks, right? And you sometimes see the approach and then see how it develops over time, because it's really interesting what you're going to see.
All right, so it's up to you. You can have it now or you can wait. Okay? I'll be back. Stay in the chair, okay? Okay. right, so I'm gonna leave and then I'll come back, okay? So you can either eat it right now or you can wait. Either way, okay? Okay. How'd you do? Did you do good? You did? You wanted to eat it, didn't you? Yeah. So did I tell you I'd give you another one? Okay, now you can have both. You need them.
You know, what I like so much about this video is that you see these differences between these kids, huge differences. Some control themselves very well from the beginning, and some just go for the marshmallow right away. They don't inhibit and control themselves at all. And this experiment was done in the 70s in the United States. And what is very interesting about it is that they followed up these kids into adulthood. And what they found is that the ones that were able to control themselves, they had far better lives. They had less financial problems. They had less divorce. They had more friends. They had less substance use problems. They had less addiction. So this is something that is already there in these kids, which relates to their prospects in life. And that means that we as a parent, and I don't know who of you has kids and who not, but we have a responsibility to help our kids develop these skills to control themselves. We should help them that they should not get every candy that is out there. We should train them. We should train their prefrontal cortex to control their midbrain, because that in the end will provide them with better prospects in life and reduce their risks in getting into trouble in all kinds of risky behaviors, including substance abuse. So basically, this is pretty much about very basic processes in life and how we can help each other from early on in our lives to become successful. So maybe that is a nice conclusion for today's lecture. What do you think?
Yes, thank you, Professor Arnt, for a lot of knowledge you gave to us. Thank you very much. Yes,
Yeah.
and also maybe I will add maybe the summary of your lecture. Yes. So we got from Professor Arnt that we also hear the relationship between drive and also control from the horse and driver story. And then we also learn about how substance work and also why addiction occurs after that. And also the dopamine pathway circuits, especially reward system, are related to the mechanism of addiction. And also we learned that the dopamine receptor will reduce after substance use. And also there are negative correlation between dopamine receptor and also cocaine self-administration. And genetics take a big role. It's about 50 until 60% of addictive disorder. And how the animal study could help scientists, yeah, Professor Arnt has told to us about many animal studies, so we can know better the neurobiology of addiction. But maybe that's the end of our session. Thank you very much for Professor Dr. Arnt Schellekens, PhD.
Sama-sama.
Terima kasih. All right, I will turn the microphone to the host, Dr. Evelyn. Thank you.
Okay, thank you, Dr. Dorothel Ikrima and Prof. Arnt. Finally, we come to the end of this event. Thank you very much for your participation in this session, and I hope you enjoy the program. And last, here's some information for you. Once again, I will inform you that the post-test link will be copied to the chat room. And then e-certificates are only given to participants who has filled the registration and pre-test before each session. So you have to fill the pre-test first before the session begin. And also post-test with pass limit value 80 can be repeated if you haven't reached the pass limit value. And the post-test will be closed at 12 a.m. midnight West Indonesian time on each day. And for the next seminar session, don't forget to join our next seminar session tomorrow on 5th November 2020. And there will be a change for tomorrow's session time, and it will be sent to your email address today. And for registration for the next session on 5th and 6th November, you can register at the link below, and we will share it on the chat room. And before the session end, we will spare 10 minutes for the audience to fill the post-test. And also, don't forget to follow our Instagram, addictiontalk.id, for further information. And once again, thank you, Prof. Arnt and Dr. Eva Suryani, psychiatrists and colleagues, and all the audience for attending this lecture. I suggest all of you to turn on your camera so we can take our photo together before we end this this video meeting. Okay, maybe we will wait for another 30 seconds for all the audience to turn on their camera so we can take our photo together.
And are we going to make a boring photo, or are we making a very nice, lively picture?
Oh, maybe it's up to you.
It's up to you. You are organizing it.
Okay, maybe we can take 2 times. First for the formal pose, and the second for the more interesting pose. Okay, maybe first for the formal pose. We will wait for 30 seconds. Okay, maybe next for the interesting pose. Okay, thank you once again, Prof. Arnt, and all the participants. We will spare 10 minutes for you to fill the post-test, and see you tomorrow. Thank you.
Thank you.
Thank you, Aaron. Thank you, Dr. Iim and Dr. Evelyn. And thank you all
Thank you, Dr.
participants
Eva.
tomorrow.